It's time for another Morning Pointe Foundation Caregiver Cafe, part of the work of the Morning Pointe Foundation, providing nursing scholarships and caregiver support programs across the Southeast. Thank you, donors, for supporting our 4 annual Seniors Got Talent shows and our 2 annual golf events. And now, bi-monthly virtual Caregiver Cafés featuring senior living experts. This episode features Dr. Mazhar Khowaja, a Board Certified Psychiatrist with over 25 years' experience in the field of Parkinson's disease. Dr. Khowaja completed his residency at the Chicago School of Medicine while also serving as chief resident and faculty. He has served as assistant professor at Wayne State University in Detroit, Michigan, and currently serves as the medical director for Deer Oaks, a private practice in San Antonio, Texas. At Deer Oaks, he works alongside 7 other nurse practitioners, serving mostly long-term care communities and exclusively focused on Parkinson's disease. Please welcome Dr. Mazhar Khowaja to the Morning Pointe Foundation Caregiver Cafe.
Hello. Hello, and good afternoon, everybody. I'm so glad to be with you guys today. Um, I do education for physicians and nurse practitioners and a lot of other professionals, psychiatrists, neurologists, family physicians. But I think today is one of the most important educational event I'm doing. That is to talk to the people who actually may have either the disease of Parkinson's disease or are caregivers of Parkinson's disease. This is very, very important for me. And thank you for being so concerned, patient and caregivers. I'm going to give you guys some information that will really explain to you another aspect of Parkinson's disease, that is that sometimes people with Parkinson's disease have symptoms that we see in other categories of diseases, symptoms like hallucinations, delusions, etc. And as a psychiatrist, I happen to treat many of those people with those kind of symptoms. I'm going to explain to you how that works in a Parkinson's brain and how can really you be part of the treatment team along with your physicians to help them take care of this important symptom of Parkinson's disease. It's going to be a lot of fun too. So I'm going to talk for about 45 minutes or so, 50 minutes, and I encourage all of you to feel free to ask questions. I'm going to be sharing some slides with you. So let's begin. Let me start to share the slides here. Okay. So that's our topic here. Parkinson's disease, more than motor symptoms. Okay. That's my introduction. So let's go into a very basic question. We all know that Parkinson's disease is a motor abnormality. It's a disease that involves tremors, masked face, problems with walking, And we all know that, and that has been quite successfully treated by neurologists. Um, but then what we also know that brain doesn't have a one-way highway kind of model inside. It has branches and it has other neurotransmitters that affects other parts of the brain. And that outshoot can cause different non-motor symptoms. Depression can happen, anxiety can happen sometimes. Other symptoms like hearing voices, we call them hallucinations, or delusions like paranoia can happen also. Let me start by giving you guys a good news first. Actually, I have more than one. I have two good news. The first good news is there's these symptoms that we call hallucinations and delusions. Collectively, we call them psychosis. Now, psychosis, first of all, is not a disease in itself. It's a symptom. Like fever. Fever is a symptom of many possible causes. It can happen from infection, it can happen from hepatitis, it can happen from pneumonia, urinary tract infection. Similarly, hallucinations, delusions, collectively called psychosis, can happen in many diseases. Can happen from psychiatric illnesses, can happen from diseases of brains like stroke, sometimes happen from substance abuse, drug abuse, delirium, etc. And Parkinson's disease is no exception. Parkinson's disease can also have hallucinations and delusions. The good news is that this is not schizophrenia. This is not bipolar disorder. Don't confuse it, because it is just a symptom that happens to be more common in diseases like schizophrenia and bipolar disorder, but can be seen in a variety of diseases, including Parkinson's disease. This is an important point, because when you will talk to your clinician, when you will talk to your neurologist or other doctors, don't be afraid to tell them if you are experiencing this part of Parkinson's disease, because it is a part of Parkinson's disease. So the good news is it is not a psychiatric illness having just hallucinations and delusions. The second good news is that not everybody who has Parkinson's disease ends up getting psychotic symptoms. It is only up to 50% of patients who end up getting some form of psychosis. And that can happen anytime during the course of illness. So keep that in mind, because that will give you an idea that if you are experiencing this part of symptoms of Parkinson's, it is absolutely okay to talk to your clinician about those. So what is this hallucinations and delusions? Well, it is important to know what it means. These words are used rather loosely, but there is scientific definitions of these words. So hallucination is a perception without the existence of a stimulus. If nobody's around you and you hear somebody talking to you, that is a perception of hearing with nobody talking to you, that is without any stimulus. That's a hallucination. It can be visual, it can be smell, it can be touch. It so happens that the Parkinson's disease psychosis has predominantly hallucinations as the symptom. And that also is predominantly visual hallucination. These people can see small bugs, cockroaches, rats, things of that nature. So that's hallucination. Let's come to delusion. Now, delusion is also talked about very loosely, but delusion has a scientific definition. And what delusion is it's a combination of two components. It is false and it is firm. This is practically important. So let's say a person believes that my spouse is cheating on me. By the way, that's called jealousy delusion. That's a relatively common psychotic symptom in Parkinson's disease as compared to other psychiatric illnesses. So my spouse is cheating on me. It's false because in reality, that's not the case. But realize that by definition, delusion is also a firm thing, which means you cannot logic it out. You cannot give evidence to the contrary and hope that the person's delusion will go away. If it went away, then it doesn't fit the definition of delusion. And therefore, it wasn't a delusion. But some people may agree with your logic. They may understand what you're saying. But tomorrow, day after tomorrow, it is going to come back again. Some people feel paranoid, as if somebody is doing something wrong to them. That's delusion. And the reason I'm giving you these definitions is because this is important to have so that you can recognize if any of these symptoms of Parkinson's disease are happening to the loved one, or if you happen to have that disease, then this is the part of the disease. Now, some people feel what we call passage, as if something just passed near them and then disappeared, or something is present in their visual field. That also usually is an animated object, like a dog or a cat. Those also are coming from the same mechanism in the brain that causes hallucinations and delusions. So collectively, all four of these can be seen in Parkinson's disease, and collectively, they're called psychosis secondary to Parkinson's disease. Okay, now, what are the causes? Now let's dive into what could be causing these additional symptoms of hallucinations and delusions. Well, there are some things that can happen to anybody, whether you have Parkinson's disease or not. And because of those, you can have this transient experience of hallucinations and delusions. So for example, if I get dehydrated, if I have a medical condition, a urinary tract infection, an electrolyte imbalance, a head injury, a stroke, or a variety of things, some medications can cause as a side effect change in the brain that manifests itself in psychotic symptoms. All those could be transient once you clear the cause. We want to do that. We want to clear all the contributing factors. But the disease of Parkinson's disease can cause internal changes. The brain chemistry changes, and that would be independent of external causes. External causes can make the psychosis worse, but it will stay even when you take those external causes out. And that is required for the clinician to do that before we can say for sure that this is Parkinson's disease psychosis. You know, most Parkinson's patients take medicine called L-Dopa or Sinemet or other medications to just treat the Parkinson's motor symptoms. And sometimes those medicines can cause the side effect of psychosis. In those cases, the clinicians can decrease the dose of medicine and see if that will help. But because psychosis can be seen in up to 50% of cases, we take those symptoms seriously, because if it is part of the chemistry change due to Parkinson's disease, then it will persist even though when you take those external factors out. Okay, now, what do you see here? It looks like a sock, looks like an animal. That is neither a hallucination nor a delusion. The stimulus is there. Either the sock is there that looks like the rat, or the animal is there that can look like a sock. The stimulus is there, something is there, but the perception is different. Now, that's called an illusion, as opposed to hallucination when there is nothing there and you still perceive something. There is no stimulus. Here, there is a stimulus, but the perception is distorted. It's misperception. That's called an illusion. So just to tell you an example of how illusions are, the magicians call themselves illusionists. They do not cut themselves in half or fly, but they make you see that way. That's an illusion. And in Parkinson's disease, if an illusion happens, or if more than one illusions happen from time to time, and are not due to poor lighting, medications, you wake up middle of the night to go to the bathroom and you see a belt and look like a snake, but you turn on the light, it goes away. If those external factors are taken out, but it's still illusions are happening, we consider the illusions also a psychotic symptom, as we do with hallucinations and delusions. So illusions is also a psychotic symptom of Parkinson's disease. Okay. So hallucinations can be, as I said, many different perceptions. It can be feeling, it can be taste, it can be body sensation, smell, hearing voices. But remember, seeing things, or what we call visual hallucinations, is the most common form of the psychosis of Parkinson's disease. Here. So this is, the gentleman is there. There is a reflection in the water, but then he's also seeing two more babies. That's not normal. There is nothing where the babies and the girl's images, and that is without any stimulus. It's a visual perception, and that's a visual hallucination. Okay. Delusion, false and firm belief. The persecutory delusions. Somebody's trying to harm or steal from me. Many times this can present in refusing to eat, refusing to take shower. Now, I work primarily in nursing homes, and we see this problem quite a bit. The nurses will say, well, there's no reason why he's refusing insulin or not taking shower. But when I talk to that person and I ask the reason behind refusal, it often will come up that there is a underlying paranoia or fear that comes up, and then we can treat it. Jealousy delusion, my partner is cheating on me, that can also actually present with irritability, throwing anger outbursts with the partner, questioning everything. I had a patient who just started to get very nasty with the wife because she would be 10 or 15 minutes late coming to see him in the nursing home, that she's been doing for months by that time. But now coming late was a bigger issue for him, because in his mind, he started to think she was late because she went to see somebody. And then reference. So TV is talking about me, or TV is talking to me. There is a song that is about me, and these people cannot be convinced otherwise. So it comes in many different forms. But remember, the paranoia is an easier delusion to ask for, and the person will tell you, but it may present in a form of anger, irritability, not cooperating with the usual that had been the case. Okay, so this gentleman in the picture is trying to see who's out there looking at him. Not uncommon. All right, so now here is an interesting part. Many times these symptoms will come early on, and at that time, the person may have full insight. The person may say, yeah, I know, I hear something when nobody's around. I know it's not normal. I know nobody else is hearing it. Or I think there is something wrong with this medicine. I feel it, but I know there's nothing wrong. So there is insight in this underlying psychotic symptom. But with time, that insight can go away. And when the insight is lost, when the awareness of it is lost, it is then a little bit difficult to convince them to even take the medications. Now, here is the issue. Why are we worried about it? Of course, we're worried about it because it's an abnormal brain activity and it can create problems in taking care of that person who has these symptoms. But we know scientifically, at least in one study, that the symptoms progressed. And so that's not like a self-limiting problem. It's not like an infection that you treat and go away because it is part of Parkinson's disease. And as you know, Parkinson's disease is a progressive or a longer lasting issue. So would be this part of Parkinson's disease. This is an important point because many people and some clinicians as well wait till the symptom is bad enough to treat. The science says that it is going to be progressive. So we try to be proactive in asking about it. We encourage patients to tell those symptoms to us so that that can be taken care of as soon as possible. As I said, keep in mind that these symptoms are just symptoms that can be seen in many different places, including dementia. Now, having the symptoms of hallucinations and delusions is neither a psychiatric illness or a psychiatric diagnosis or a dementia. It's not Alzheimer's disease. There are patients with Alzheimer's disease who may have the symptom of psychosis, as I explained about the symptom of fever. But per se, having hallucinations or delusions doesn't mean the person has dementia or Alzheimer's. I personally encourage my clinicians, and I'm suggesting that anybody who thinks they have hallucinations, pay attention to see if these are happening either at the time you're going to sleep or when you're coming out of sleep. Are these part of the sleep architecture? Vivid dreams, if remembered, can be viewed as if these were hallucinations. Hallucinations are very distinct when you're fully awake. That's when they happen. Excellent. So let's move on to the risks and why it happens. Okay, so 50% of people with Parkinson's disease may develop hallucinations and delusions at some point during the course of disease. This is important, at some point, which means if the person gets diagnosed with Parkinson's disease in 2023, hallucinations and delusions may not happen right there and then. It can happen anytime after that. So it could be several months, several years before you can see the psychosis, or it can happen right along the time when the Parkinson's disease happens to occur. It can be any time during the course of illness. Okay. Now let me take you guys inside the brain of a person who happens to have Parkinson's disease. We have many different neurotransmitters in the brain, and they do work. They are the ones that make you move your arms, make you feel good, make you feel bad, make you feel angry, make you think, etc. There is a neurotransmitter called dopamine, and people who have diabetes, their body doesn't produce enough insulin. That's one type of diabetes. If the body doesn't produce enough dopamine in one particular area of the brain, that can result in tremors, shuffling gait, masked face, bradykinesia, and hence the cluster of those motor symptoms called Parkinson's disease. Okay. Now, interestingly, the psychosis that we see with diseases like schizophrenia is actually from an increased level of dopamine in a different part of the brain. We had been in the past treating hallucinations and delusions of Parkinson's disease by lowering the dopamine as if it was the psychosis of schizophrenia. And when the medicines we used did that, they made motor symptoms worse because motor symptoms was because of less dopamine. And the older antipsychotics or antipsychotics FDA approved for schizophrenia or bipolar are designed to decrease dopamine, then obviously the motor symptoms could get worse. We don't want that. Now we know that the psychosis of Parkinson's disease is primarily not from increase of dopamine. It is not from dopamine system. It is primarily from serotonin system. Serotonin system is involved in depression, anxiety, and now we know it's also involved in the psychotic symptom of Parkinson's disease. It's a good news. It's a good news because we can treat these hallucinations and delusions of Parkinson's disease by addressing the problem in the serotonin system without having to lower the dopamine. And therefore, we can treat the hallucinations and delusions without taking the risk of making the tremors and shuffling gait and masked face and all the Parkinson's symptoms worse. In other words, we don't want to make Parkinson's disease motor symptoms worse by treating psychosis with medicines that primarily decrease or block dopamine transmission in the brain. That's a very good news. And that's what I do in my practice. Okay. So what happens if you don't treat the hallucinations and delusions of Parkinson's disease? Well, there are consequences. Obviously, there is discomfort. If you're feeling paranoid, if you don't know where your wife is, if you don't know where your husband is, if you don't know if the food is right for you, if the medicine is right for you, there's discomfort. There could be denial or refusal of treatments, etc. Behavioral problems can set in, agitation, difficult to manage those people. And we know that it increases the chances of hospitalization. So on my left hand, if there's patients with Parkinson's disease and no psychosis, and right hand, there are patients of Parkinson's disease with psychosis, these people are more likely to get admitted into the hospital. Of course, there is a huge emotional burden, caregiver burden. Think about if I lived with my wife for 50 years, took care of her, and now she's accusing me of cheating when there is no reality to it. This will bother me because we all are human. So there are consequences. The point I'm making is not just on the person who has hallucinations and delusions, but the ripple effect on the caregiver and the rest of the family. Okay. So can we treat it? Can we treat these hallucinations and delusions? Yes, we can. We do rule out all other causes. We want to approach it with non-pharmaceutical interventions first to make sure that we are not using medications if we can avoid. The idea is to use less medications. And sometimes it requires to just decrease the other medications that could be causing or contributing to the symptoms of hallucinations and delusions. It's a tough task because many people, at least in my practice, are already at the lowest dose, or if you don't decrease the dose of their Parkinson medication anymore, it can make their motor symptoms worse. Okay. Now, let's say I have Parkinson's disease and I recognize my part of Parkinson's disease is having visual hallucinations. I need a plan of action. I need to recognize that this is not going crazy like a psychiatric illness. This is not an indication of dementia. It is part of my brain chemistry that's causing motor symptoms and now hallucinations and delusions. So for me to get maximum benefit of treatment, I need to be proactive in telling my loved ones and also my clinicians so that that can be evaluated, other causes can be ruled out, and if needed, could be treated. You see, many physicians don't spend much time with the patients. That's the reality. Many physicians are hyper-focused. The spotlight is on the motor symptoms. And they do a great job in treating motor symptoms. The psychosis gets on the surface and only then attention is given and treatment is given. What the point I'm making is that if you understand it is part of the illness and you are outside of those fears of psychiatric illness and dementia, then experiencing any such symptoms or observing your loved one experiencing or acting on such symptoms, it's not a bad idea to go ahead and discuss it with your healthcare provider. Good advice might come. Simple things like altering medications may just help rather than adding other medicines. And if that's required, then that would be required. Okay. So this is great. It's a triad. It's like the person who has the Parkinson's disease is not just person that has Parkinson's disease and the person who writes the medicine, the doctor. You have caregivers. It's a connection. It's a more of a whole setup to address this issue. There are other things that can be put in this slide in the triad. I think it is not a bad idea to every once in a while, you can have your Walgreens or CVS pharmacist or even your doctor's pharmacist to just review all the medications you are taking, not just being given by a neurologist, by your cardiologist or other specialties, and just take a look and see if there is overwhelming anticholinergic effect of this, any medicines that might be contributing to insomnia that leads you to have the irritability. There is any drug interaction. I think pharmacists can play a big role in streamlining the treatment as well. I try to encourage people to do that, even in my family, because it so happens that different doctors may not know what the other person is doing. Okay, so now that you have this in your pocket, the probability of the hallucinations and delusions happening in the course of Parkinson's disease, you now understand it's a chemical imbalance that can be seen in 50% of cases. You have established a plan. Either you are going to keep an eye on it, your loved one will keep an eye on it. And if that comes up to the surface, then there is a trip to the pharmacist, trip to the physician. Let's get it resolved. Let's take all the contributing factor out and let's see if we need to treat it. Remember what we know from at least one study, that most of these symptoms do progress. They do not subside on their own. Okay. So what did we say? We said that Parkinson's disease is more than motor symptoms. Many symptoms can happen with Parkinson's disease. One of the symptoms that is seen in 50% of cases is hallucinations and delusions. It is part of the disease. Hallucinations, delusions, illusions, sense of presence, sense of passage, all of these collectively can be part of the psychotic symptoms of Parkinson's disease. It's from brain chemistry. It is not somebody's fault. It cannot be reasoned out. If these are persistent, all the other factors are taken out. That is part of the brain chemistry. What is the most common psychotic symptom of Parkinson's disease? It is visual hallucinations. You can have any different type of hallucinations, but in terms of statistically, visual hallucinations being the most common. And unfortunately, they can get worse over the course of time. Untreated psychosis can lead to complications like hospitalization, caregiver burden, impact on overall health. In some studies, there are other consequences mentioned as well. And what can you do to help your clinician to manage your non-motor symptoms better, particularly psychotic symptoms, is to be proactive. Proactive in being aware of the reality of it, proactive in talking to your loved one about it. Your loved one, caretakers can keep eyes open for any of those symptoms coming up. And at that point, if that happens, you go and talk to your doctor, who I know would be very happy, because clinicians want to help. their patients to look into it, confirm it, take all the contributing factors out, and if needed, give you medicine. Okay, so now what medicine? There is only one FDA-approved medicine called pimavanserin. It's a fancy name. It's a generic name. The medicine is called Nuplazid. It's an antipsychotic medicine, but it is not FDA approved for any psychiatric illness. It is not FDA approved for schizophrenia, bipolar disorder, depression with psychosis. Psychiatrists cannot use it for those diagnoses. You have to have Parkinson's disease psychosis to be able to take Nuplazid. So one disease, one FDA-approved medicine, and that's it. It's an antipsychotic, and all antipsychotics come with black box warnings. Now, what is a black box warning? It is a warning that FDA says, watch out. And they bold it. It's a box warning, which means you have to pay very big attention. It says the following: medicines like Nuplazid can raise the risk of death in elderly people who have lost touch with reality. That is psychosis due to confusion and memory loss, also called dementia. If you're elderly and you don't have dementia, this warning requires the presence of dementia. It also says Nuplazid is not approved for the treatment of patients with dementia-related psychosis, and no medicine is. But it also says something very important. Nuplazid is not approved for the treatment of patients with dementia-related psychosis unrelated to hallucinations and delusions associated with Parkinson's disease. Let me break it down because this is important. If somebody who has dementia and they have hallucinations and delusions, and your doctor determined that hallucinations and delusions in the presence of dementia are because of Parkinson's disease, Nuplazid is FDA approved. You have that in writing. So that's why we try not to use medications like antipsychotics, patients who have dementia, unless it is absolutely necessary. But if your psychosis is from Parkinson's disease, even in the presence of dementia, Nuplazid is FDA approved. Okay. Comes in only one strength, one dose, 34 milligrams. That is the dose for any age, any gender, any body weight. It's once a day, 34 milligrams a day. We know that it may have mechanisms that we do not know, but we do know that it works on the serotonin system. Remember, we don't want to have a medicine that blocks or lowers dopamine to treat psychosis because that can make your tremors worse. The good news is that we can treat hallucinations and delusions by working on the serotonin system, and Nuplazid does that. It is primarily a serotonin system medicine, and therefore we shouldn't expect to see the worsening of the motor symptoms of Parkinson's disease. So what happened when people took Nuplazid? Okay, the majority of patients, and I'm using the word majority here because nothing works on everybody. There is no medicine. What we know is what works in majority of cases, and that had superior efficacy compared to placebo. And in the clinical studies, that is what Nuplazid did. People who took Nuplazid as opposed to those who took placebo, the Nuplazid group had significant improvement, either in frequency or intensity of hallucinations and delusions. These are the people who had hallucinations and delusions because of Parkinson's disease. They were on other antipsychotics, obviously for schizophrenia and bipolar, but those were stopped. People were washed out, put on either placebo and Nuplazid, and the placebo group had a statistically significant improvement, and that's why it is FDA approved for this disease. That interestingly, about 13% of patients not just improved, the symptoms actually totally went away. We don't see that in psychiatry a lot. with any disease. Depression can get better, doesn't go away. Seizures can get better, completely don't go away. Blood pressure can lower, but there are days when it is high. You take insulin, you're fine. One of the days, insulin goes up and down. Pain, chronic pain, with all the medicines that we have on the planet, people still experience pain. So total disappearance of symptoms, generally speaking, is not very common in medicine. But there were about 13% of patients who, in a 6-week studies, did have complete resolution of all their hallucinations and delusions. So good. Okay. 25% of patients actually had no response or had some worsening of their hallucinations and delusions. And that is also not surprising because not everybody responds to any medicine all the time. So how fast can one see an improvement in hallucinations and delusions? Well, it may take 4 to 6 weeks. You can see response, you can start to see improvement, but to get the plateau or get to a steady state, it may take up to that time. And remember, we are treating brain chemistry here. We are not just sedating a person. I can give anybody a powerful sedating medicine, and their symptoms, whether it is hallucinations or pain or anything else, will just go away. The person will be sleeping. That's not the goal here. The goal here is that the person is fully functional. We are monitoring their hallucinations and delusions. It may take up to that much of time. Okay, if somebody is on Nuplazid, don't stop it on your own. It's best to talk to your doctor if for any reason that needs to happen. Okay, so now let's go back to what happened to their motor symptoms. We don't want to make them worse. Well, we shouldn't see worsening of motor symptoms because Nuplazid did not really touch the dopamine system. We are now playing with the serotonin system. And in the clinical studies, that is exactly what happened. Nuplazid at 34 milligrams, which is the maximum dose, did not make the motor symptoms work. You can take Nuplazid with your Parkinson's medications. There is no need to adjust the dose or come out of those Parkinson's medicines. It's more of an add-on for hallucinations and delusions. It is not really doing anything for motor symptoms, not making it worse or better. And the medications for motor symptoms can be continued as you were taking before. Side effects. Nothing is full of side effects. This is important to keep in mind that anything you take has the potential for side effects. We really measure the side effects more carefully because that's what we need to look for if somebody's on Nuplazid. So nausea, 7%, swelling in the legs and arms, 7%, compared to placebo, 4 and 2%. So that would be considered the most common. Feeling confused, 6% compared to 3% in placebo. Hallucinations as a side effect, 5% compared to 3% in placebo. Constipation, 4%, and compared to 3% in placebo, and changes to normal walking. And this is important because we don't want the gait to be any more high risk for falls. We don't want falls. So this is important too. So these were the most common side effects that we saw. And when I use this medicine on my Parkinson's patients, we go and look for these. Okay. When not to take Nuplazid when you are allergic to it. Common sense, but if somebody's allergic, you will find it and we don't use it. All antipsychotics, including Nuplazid, can potentially cause what we call QT, interval prolongation. It's something that the doctors do an EKG for. The Nuplazid is no exception. It can increase the QT prolongation, the QT interval. But what does it mean in real life? Well, if you were on no medicines that cause QT prolongation, and if your heart has no problems, then FDA does not require us physicians to do EKG before or during Nuplazid. So the QT prolongation is between 5 and 8 milliseconds. But if you are taking medications that can also cause QT prolongation, or if there is a pre-existing, if there is a heart condition, in that case, even 5 and 8 milliseconds can become important. And in those cases, your clinician will make a decision to either do an EKG or say, we don't have to worry about it, or may not even use Nuplazid. But that is something that antipsychotics have as a class. Okay. There are certain medicines that can affect the liver's factory, the liver's mechanism to metabolize certain medicines. Okay, what does it mean? When Nuplazid is taken, it goes in the liver breaks it down. Now that is the enzyme system. If you are taking a medicine, let's say Tegretol, that affects the enzyme system, it can make the enzyme work faster and Nuplazid will get out faster. In that case, 34 milligram may not be enough. Okay. The opposite can be true also. You're taking a medicine that slows down the enzyme. Nuplazid may not get excreted as fast as it would otherwise. And in that case, your clinician may use a smaller dose. That is something that we clinicians work. Your job is to tell us what you're taking. That's why that overall evaluation of medications becomes so much more important. Okay, so this is the 34 milligram. It actually says, this is so funny, they have to write not actual size. Taken once a day, with or without food, any time of the day. And the reason you can take any time of the day is because it doesn't cause any sedation. Most of my patients take it in the morning. It may not help you sleep. It may not disturb your sleep. It's generally sleep neutral. So once a day, with or without food. How can one get Nuplazid if needed, if there is coverage issue? Acadia, and I'm speaking right now, by the way, I should have said in the beginning, I'm speaking on behalf of Acadia right now. Acadia has a system. Acadia is a manufacturer of Nuplazid that can assist with getting it if there is coverage issues. It's called Acadia Connect. And I have personally used this system for some of my patients. This happened more so early on when it was a brand new medicine. It is now a bit easier to get. The idea is if you need it, you should be able to get it. And that's the motto here. So now let's go to summary number 2. We talked about Parkinson's disease and psychosis. Now we're talking about the treatment of Parkinson's disease psychosis. It is really a simple decision for your clinician. There is only one FDA-approved medicine for this Parkinson's disease psychosis, and that's called Nuplazid. Majority of the patients in the study, when they took Nuplazid, their psychosis improved. Otherwise, you would not have FDA approval. But more importantly, their motor symptoms did not get worse. And that's the key. You don't want to make that worse. If needed and taken Nuplazid, any of your Parkinson's medications do not need to be adjusted. It is an add-on. Common side effects that were seen were swelling of the legs and arms, nausea. Those two were at 7% compared to 4% and 3% in the placebo group. Confusion, hallucinations, constipation, etc. I tell you what, it reminds me of a patient's very, very early on when Nuplazid came in. I had a discussion with the patient's family and actually their physician also, because the family wanted me to talk to the physician. We discussed what I discussed with you guys, but physician to physician, we talked about how it can be used in patients who have liver disease. It can also be used in people who have kidney disease. Those two do not have much impact on the use of Nuplazid. And I'm throwing this because don't think that if you have a pre-existing kidney disease or a liver disease that you shouldn't be talking to your doctor about the hallucinations and delusions, because as far as Nuplazid is concerned, those two are not an issue in terms of using it. let's watch a video. So I'm gonna start a video, and then this is our 2 minutes video. It's very interesting, and see what happens to this patient.
My mom and I were always very close. She's like a best friend to me and a great grandma to my children. I remember the day that my mom was diagnosed and the doctor confirmed that she did in fact have Parkinson's. You know, my mom was pretty devastated with the news. My mom understood what was happening physically to her with motor skills. I don't think that she expected any of the other symptoms that can go along with Parkinson's disease. At first, the hallucinations were, you know, something that you could really believe. And then they started progressing where she would see people at night, because there would be, you know, groups of people that would be watching her when she slept. She was afraid to go in certain rooms of her house, that the people would be there. She didn't want them to see her. And sometimes it became a little bit frightening for her. That's when we really started growing more concerned. Of course, I wanted to solve it and fix it and help her, and I couldn't. I would take her to the doctor fairly often, and you know, one of the things that I brought up during her checkup was that she was having, you know, some non-motor symptoms, the hallucinations. We discussed it, and he confirmed that what it was hallucinations. You know, it can be part of Parkinson's disease. It wasn't really a comfortable conversation for me to have with my mom there, reporting to him that she was in fact hallucinating. I felt kind of awkward, and I hated to have to say that in front of my mom. It was a hard discussion. I felt some relief in talking to her doctor and him, you know, reassuring that it was part of the disease, but still it was not easy to hear, because she's not just anybody, she's my mom. I really urge anybody that's going through this to open that line of communication with their doctor. And I just know how distressing the hallucinations were, and the delusions and the fear for my mom. And if I could help like one other person to not go through that and not be afraid, then I'll just feel like I did something really good.
Okay, let me pause here, and I would be very happy to answer any questions. This is basically the whole presentation. So thank you so much for listening, and I will open up for question and answers.
Hey, Dr. Khowaja, can you hear me?
I can hear you.
Oh, good. This is Amy Clark with Morning Pointe, here to help you with some of the questions that have come in this evening. Thank you so much for the presentation and all the details and solutions. So here is a couple questions. I'll pull them up here.
Yes.
The first one is, what do you recommend to do for your loved one when they are in the middle of a delusion or hallucination and absolutely believe that it's real?
Excellent question. This is a very practical question. Okay. So this is in the middle of a delusion. What you want to do is to not argue. By definition, it is firm. You don't stop logicking it. Stop giving evidence otherwise. The best would be, at that point in the middle of the delusion, is to just stay calm and let it pass. That's number one. Number two, maintain safety. If the person believes somebody is outside with a gun and wants to take a gun and start shooting, that's an extreme example. You don't want to do that. So safety. But the third is the most important thing, which is understand it is an abnormal activity of the brain, and you cannot and shouldn't take it personally. I've seen families feel devastated when the father or the mother accused of stealing money. I've seen people go in the corner and cry because the accusations that are made by a person who's in the middle of a delusion. Having said that, once the crisis is over, then you take that symptom seriously and get treatment so that it doesn't get to the crisis again. The point number 2 I made of maintaining safety, sometimes in extreme cases, we end up using medications to just take away the crisis. And those medicines are usually used on as needed basis, and they are mostly sedating medicines. So the person gets the medicine, either gel or injection or tablet, and the person just sleeps for a few hours. And the hope is that emotional crisis, you see, the delusion was always there. It is the emotional reaction to the delusion that now you are seeing and calling is crisis. The foundational problem was already there. So the lesson here is you don't take it personally. You don't argue logic or try to prove it otherwise. And you maintain safety. And the fourth thing is you make sure your plan of treatment now includes something that the person takes so that these delusions don't keep coming up and don't get worse over the course of time. Thank you.
Yes, thank you. We have another question here, and we do invite anyone to put in some questions in the Q&A, and Dr. Khowaja will be happy to take additional questions during the final moments of our show. Here's another question. At what point do you recommend a senior care community for around-the-clock care and support?
Yes, that happens. This question is important from another point of view. I'm going to do that and then answer. People who have Parkinson's disease and people who have Parkinson's disease with psychosis, these people are more likely to end up in long-term care or nursing home because it will be difficult to take care of them. It really boils down to a few things. Number one, the resources that you have at home. I have patients whose families decided to have a nurse around the clock and not bring the person nursing home. The short answer is, where would the person with Parkinson's disease and psychosis will be safer? Is it home or nursing home? That's part one. Where would the person be safer? The part two is mostly missed, but I'm going to say it because I think it should be equally important. And the part two is the burden on the caregiver. If a Parkinson's person with psychosis has a spouse who herself or himself is in late ages and is in an overdrive, working so hard, has given up all the activities that he or she loved, can't sleep, the caregiver burden should also be part of the decision as to when this person with Parkinson's disease psychosis needs to go in long-term care, because the other person, the other spouse, the other family members, child, daughter, spouse, anybody, their life is also important, because we know that caregiver burden can actually have significant consequences. These are studies, this is science. We know from common sense also. So those two things, what is best for the person who has the disease, and also what is also important is what is needed for the caregivers. If you combine those two, you will get your answer as to when this person needs to be in a long-term care.
Thank you, Doctor. Are there any other commonly asked questions during your presentations as we begin to wrap up here? Anything else?
I see one more question popping up. I don't know if you want to read that.
Oh, yes. I see
And
it.
there's one in the chat as well.
My apologies. Here it is.
No problem.
If you suspect someone is experiencing hallucinations, should you address it with them? If so, how do you approach the subject?
Yes. So when you observe somebody talking to himself, or when you observe somebody who was trying to lean forward and pick up something, it looked like an animal because the gestures suggested. asking and getting an affirmative answer is only verifying it. So observation is extremely important. But your point, should we ask? The answer is yes. And the way you ask can vary from very indirect way to very direct way. The very direct way is very simple. Are you hearing voices? Do you see things that you think other people may not be seeing? That's a very direct way. But a more productive way would be more conversational ways. So, for example, Dad, I just heard you talking to somebody. Who are you talking to? Or let's say I'm a physician, I see a patient who has refused medications, and I suspect that is because the person is paranoid about the medicine. So I will not say, is anybody trying to give you poison? That will be way too direct. I will have a conversation in 2-3 sentences. I'll give you example. So how are you feeling, Mr. Smith? Do you think you are getting the medications every day? Do you think you are getting the medications that you should be getting? Is there anything wrong with them? Okay, tell me what is wrong with them. These are not the medicines you should be taking. Then is somebody trying to give you the wrong medicines deliberately? You see how I'm going slowly towards detecting paranoia. I'll give you another example. I go in the room and I say, Mr. Smith, how are you doing today? And then I will ask, how do you like this place? Let's say the person is in assisted living. Do the nurses keep your room clean? Now I'm asking these questions to finally ask if there are visual hallucinations about bugs and rats and cats. So do they keep your room clean? No. Okay, well, what is it? Do you see dirt? Do you see anything else? I saw bugs. You see cockroaches? Where are they? On the wall, on your bed? So a couple of questions led to what I wanted to ask, but it was more of a conversational. So that would be the range where you would go from absolutely direct to starting a conversation indirectly and then getting to where you want to ask that specific question. But don't do the mistake of not digging into it, because that would just mean that you didn't explore. It might be hallucination, it might be a delusion, and if that's the case, that needs to be addressed and taken to the physician.
Okay, we do have another question.
Yes.
This person typed, I'm not sure how to handle the situation when a person I care for has multiple self-described quote unquote episodes a day, when the tremors are severe and or the body freezes up and they constantly request EMS, while other times they walk as if they have no diagnosis at all. Is that a real thing? Can they seem fine one moment, then the next be experiencing an episode? How do I calm the situation?
Okay, so this is freezing of the motor symptoms. This is not really, from what I heard, it's not a hallucination and delusion problems. And there are Parkinson's characteristics where you have this on and off phenomenon. Smart neurologists can really help you with adjusting the medications from long-acting to short-acting and as-needed basis. That would be really not that difficult to be done by a movement disorder specialist. See, neurologists have different specialties. I don't know where this person who asked the question lives and what is the availability of clinicians, but the fact that we have so much of Zoom practices these days, neurologists can specialize in headache, they can specialize in movement disorder, and Parkinson's disease falls in movement disorder specialists. So it should not be that difficult to take care of that. But this is not a hallucination or a delusion problem from what I heard.
Okay, thank you very much. We do not have any more questions at this time. Is there anything else that's frequently asked or anything else that you'd like to add, Doctor?
Yes, I have just one more thing. So the fact that I showed you a slide that said that this hallucinations and delusions can be progressive is actually acknowledged by CMS. And this is important. because CMS is an independent body and they oversee all the activities in the nursing homes. And their goal is to make sure that people are not getting medications without a reason, or they are on the smallest amount of medication. So CMS actually came out and said that Parkinson's disease psychosis is a progressive and enduring disease. And they also mentioned that the gradual dose reduction of Nuplazid may be contraindicated. This is important for those people who have loved ones in the nursing homes, because in the nursing homes, all antipsychotics that the people are taking for various reasons, we are required to do gradual dose reduction to either take the medicine completely out or come to the smallest dose, even if the person has a schizophrenia and bipolar. So this is called gradual dose reduction. It is a standard practice. I do it, all clinicians do it. But the fact that CMS actually said that Parkinson's disease psychosis is enduring and progressive and gradual dose reduction may be contraindicated, which means should not be done, is a further verification of the one study that I showed, that this can be, and most often is, a progressive problem. So point I'm making, the last point, is that do not pay attention to it, because there is enough evidence that this is something that is like Parkinson's disease, that stays and can get progressively worse. If you remember this, I think most of the things that I said otherwise will make perfect sense to go to the clinician and keep your eyes open and be on an outlook for that.
Okay, Doctor, we did have one more question pop in, and then you can also feel free to stop sharing your screen and we can put up your contact information as well. The question is, what are the reasons for hospitalization?
Generally speaking, Parkinson's disease, many reasons. I do not have a study that can tell me falls is X percentage, psychosis X percentage, infection is X percentage. But pertinent to what we have talked, we know that the people who have Parkinson's disease with psychosis are more likely to be hospitalized than those who have Parkinson's disease and no psychosis. So the chances of hospitalization do increase if you have untreated psychosis. I'm going to extend my answer with one more offshoot. Let's say a Parkinson's person sees a visual hallucination of seeing something, let's say sees a snake. I have a patient who had that hallucination. The normal human response to that would be either to go up and towards the snake to kill it, or to go up and go away from the snake so the snake doesn't bite you. Well, both for a Parkinson's person can be risky, because they have impaired motor symptoms. And by risky, I mean that hallucination can increase the chances of fall. And fall would be another reason for hospitalization. So you have a consequence of psychosis or untreated psychosis that can also increase the chances of hospitalization. So talking about psychosis, yes, it does increase the hospitalization for Parkinson's patients.
Okay, thank you so much. That is all of the questions we have. If you want to say all of your goodbyes, Dr. Khowaja, and thank you so much for tonight's presentation.
I am so thankful that I had this opportunity. I think if there is anybody who has any questions, Amy, you have my contact. I'm here to help. But this, I hope, was helpful, and I would be so happy to answer any questions even after all we finish and later on. Thank you, everybody, for listening. Have a great evening.
Thank you again for joining us for another Morning Pointe Foundation virtual Caregiver Cafe. And thank you, Dr. Mazhar Khowaja, a Board Certified Psychiatrist with Deer Oaks Private Practice out of San Antonio, Texas, for sharing your expertise. Be sure to join us for another virtual Caregiver Cafe. Until next time, thank you for joining us. To learn more about the work of the Morning Pointe Foundation or watch any of our previous Caregiver Cafés, visit us at morningpointefoundation.com.